Thank you, Lakshmi, and good afternoon, everybody. So we are coming to end of our session, but I think we have two more sessions to go. Okay. Yeah. We have been talking about the symptom control, communication, ethics, etc. But now we are moving to another part of uh, palliative care, uh, by which actually we can make the patient peaceful while he dies. So there is something called as dignified death. So we will hear more about what is dignified death and things like that from Dr. Roop Gursahani. And we know we are actually managing the end of life of many patients. But are we doing the right things? And we have been practicing the end of life care since our internship days. So when I was doing my internship, whenever a patient is terminal or gasping, the nurse will call the house surgeon, and the house surgeon will come, immediately give injection hydrocortisone, darafilling, put oxygen mask, uh, then possibly chest compression. So this is what routinely being practiced when I was doing my house agency some 17, 18 years back. So are we doing the right thing? So today, Dr. Roop Gursahani will be talking regarding this. So Dr. Roop is a neurologist, basically working in Mumbai with Hinduja Hospital, and he is interested in palliative care, and he is in the forefront of neuro palliative care. He is also in the steering committee for end of life care in India task force, uh, and he is helping us with the teaching programs. So, Dr. Roop, welcome, and it's over to you.
Thank you. Am I audible?
Yes, you are audible.
Okay. Thank you so much. Always a pleasure to speak at Paliminda's functions and to interact with all of you. So I'm going to, in a minute, while I find my mouse, yeah, and figure out my screen. Right. So you can see my screen, and I'm going to speak on end of life care. I'm going to actually give you a fairly wide perspective. And I'm starting by asking this basic question: do we all think about our own deaths? And if we do, typically what we all do is think about death as though it was an abstract thing which will just happen someday. Because when we do think about it, we are all worried about dying with pain and suffering. And this is a old joke attributed to Woody Allen. And he's said to have said, I'm not afraid of death. I just don't want to be there when it happens to me. Right. So when you look at quality of life, we don't really think that quality of death matters. Quality of life is a very positive evaluation and so on, depending on physical health, psychological state, and so on. But think about it, that there is a very negative part to this quality, and that is quality of death. And you have to minimize that negative quality by giving a good life till the very end. And you can do that by minimizing suffering. And if possible, you have to see if you can measure it and if you can work on improving it. Now, this actually was an exercise that was done. It's still ongoing, but it's not done for, say, a single person. It's been done for countries as a whole. And well, when it was first done in 2010, they looked only at end of life care, 40 large countries. If you see, India is there right at the bottom. Then in 2015, they widened it and they looked at all of palliative care. And fortunately, because India has, say, bright spots like Kerala and Pallium India, well, we were not the worst as far as palliative care was concerned, and our quality of death, out of about 67 large countries, we were 13th from the bottom, and fortunately, both Pakistan and China were below us. Right. But that is not what it should be. And let me tell you what it is like to die in the best country in the world to die, which is actually the United Kingdom. This has been worked out in terms of various parameters. So a UK citizen can expect palliative care at home and admission to a hospice when needed to ensure an almost pain and symptom free death. All the information that she wants will be conveyed sensitively to her family and her with due regard to her autonomy and own choices. Her values and wishes for end of life care will be discussed with trained counselors and it will be recorded in an instrument that will be enforceable. If she's unable to communicate and you have complex issues of ethics, law, then you have something called the UK Court of Protection. It's not like apply to the High Court and get a date after 6 months or 1 year. No, this is the UK Court of Protection and it hears these cases expeditiously, specifically to put all these things together. And all these services are without charge by public agencies. In fact, the United Kingdom does better than countries that are richer than it. Why is India not a country to die in? Well, our healthcare spending is poor. The public sector is badly underinvested. The private sector has no awareness of these issues. For palliative care, there is government policy, but it is not implemented. And even the public doesn't have much of a demand for palliative care. If you ask for palliative care, except Kerala, it is highly variable. Even elsewhere, you're not going to get it. It won't be covered by insurance. If you want psychosocial support, maybe in the large cities, and public awareness and volunteers, only Kerala. And the dying matters coverage in the press is minimal. We have constitutional validity, which means the Supreme Court has said that these are things that we can manage, but unfortunately, the procedures have not been settled. Doctors don't know what to do. Whatever it is not really enforceable easily. And it's only now that we are beginning to see, since I'm part of this initiative, we are beginning to see some movement in something called Do Not Resuscitate. Uh, that's using CPR at the end of life and life support. So we are beginning to see some movement, but we are still far behind. And the problem is that end of life care is not just about medicine. It's about ethics, it's about legislation, it's about politics. Medical decision making becomes very complex at this point, and under it all is individual human suffering. And because it is actually everybody's business, government, medical profession, legal profession, civil society, as you can imagine, everybody's business is nobody's business. Now, it's important for us to remember the boundaries that are applicable here. You have been oriented to palliative care, which is applicable to all serious health related suffering. And then an individual nears the end of life, which means, say, from about a month, for some months to 1 year, when you know that cure is no longer possible, and terminal care is when the process of dying is about to begin. Actively dying is when it becomes irreversible. So, how do you approach this? Your approach basically shifts the focus to symptom control, comfort, dignity, quality of life, and quality of dying with support for the family, without focusing on treatments that aim at cure. And this runs in when the condition is considered non curative. Ideally, it should be managed with either home or hospice care. So, as you can understand, the most important things are symptom management, psychosocial support, and communication. Uh, Anybody who's able to communicate at this point wants to part on a good note. So I'm going to show you actually three patients. Two will come up in the first part of this talk, and the third will come up later. The first is this gentleman who was a retired bureaucrat, the other is a retired businessman, both elderly. Remember, if you think of trajectories of disease when people are towards the end of life, sudden death, uh, Sharp end, there's nothing more after this. No question of palliative care or anything. But what about, say, something like cancer? In cancer, typically it affects people in their late 60s, and until the diagnosis, and for some time after that, they will do fairly well. And then once the cancer goes past the point of no return and chemotherapies and so on don't work, you enter what is called the waterfall trajectory, where it will end in death after a fairly predictable period of time. As opposed to people who have organ failure. This is somebody who's got bad blood pressure, diabetes, whatever it is, organ, maybe heart, lung, liver, whichever one is failing. These are people who will get into crisis, enter hospital, come out, not so good, and so on. This is called the looping trajectory, as opposed to waterfall, looping. And this is somebody who's very elderly, usually late 70s, early 80s, and who, as it is not functioning too well, is at a low level of function, and then dwindles and dwindles and dwindles and dwindles until death. So you can understand these are the three basic trajectories. Of course, there are overlaps and so on. So as I said earlier, sudden death, there's obviously no need for hospice or palliative care. Terminal illness, well, actually you'd say palliative care starts here, but usually it starts somewhere around here. So what about our gentleman who's living in Mumbai, who gets intermittent constipation, blood in the stool, colonoscopy picks up a malignancy, which is confirmed, and as always, the consultant, well, dumps it on the family physician. Says, collect the reports and and send the patient to an oncologist. Well, we'll come back to this. If you look at organ failure, well, again, you can get palliative care throughout the course of illness, but it's quite uncommon. And there is one more trajectory which I haven't shown in that first panel, and that is of somebody who is actually functioning well, runs into a problem which could be something that hits the brain, either a stroke or traumatic brain injury, or sometimes it's not even directly affecting the brain. It can even be hip fracture in a very elderly patient. And suddenly they have dropped in level of function. And from a normal functioning individual, they have dropped to the dwindling trajectory almost within a period of weeks. And then this is called the catastrophic event trajectory. Right. And the last, of course, the old elderly trajectory, you know that I've told you, palliative care is valid throughout. So I've shown you one patient. We are at the beginning of his story, journey with cancer. This is my other patient. He is a retired bureaucrat. In 2014, first gets forgetful, diagnosed early dementia, and at this stage, he himself asked the neurologist, "Ab kya hoga?" But there's no discussion. He continues with his active social life, although he doesn't do too much physical exercise. Just before this onset, he had actually given up all the major assignments that he had because he said, "I can't cope." And then from 14 to 17, his dementia gradually worsened. Now, please think about it. These could be your patients, my patients. We know them at the beginning. We know that these will go down. What do we do about it? And if possible, you can answer it in the chat box. I'll take those once we get into the cases, and I'll kind of answer them there. The thing is that when you look at something like this, patients expect physicians to tell them what will come in the future. And because our patients are also evolved, they expect this prognostication in a fashion that is honest, accurate, and optimistic. And that is not very easy, except if you are trained in palliative care. So think about it. Can we recognize that somebody is nearing the end of life? Yes, there are 4 triggers that point this out. The first is called the surprise question. The second is called general indicators of decline. Like you see somebody in the trajectories that I showed you earlier, and either by general indicators or specific indicators within those conditions, as the person is deteriorating, you can find out when, what their position is on the trajectory. The last is decisional. When at some stage in that trajectory, the patient and the family decide that enough. For instance, somebody with kidney failure says, I'm not going back to hospital, no dialysis. So, what about the surprise question? Now, the surprise question is and gets an intuitive answer. It's an intuitive answer which puts together clinical features, comorbidities, the associated illness, social and other factors to get a whole picture of deterioration. And the question that you ask yourself is, would I be surprised if this patient were to die in the next one? Or you can change the time frame and you can say surprised next few months, weeks, days. And intuitively, if you're an experienced doctor, then you will actually have an idea that no, I don't expect this patient to be around next year at this time. Or I don't expect this patient to be, this is June, I don't expect to see him by October or November. And you will be surprised that with experience and of course a certain amount of careful training of your own prognostic senses, you actually can get to about a 70 to 80% accuracy. What about general indicators decline? Say, whatever be the condition, if somebody's performance is declining, not able to take care, in bed or chair more than 50% of the day, and needing more and more assistance in activities of daily living. Of course, you can put numbers to this. There are ways in making this systematic. This is also something that can give you a number. Now, if you will get this presentation, so you'll see this. This is the Karnofsky score, and you can actually see this is used for cancer, and you can see as somebody goes down from the point that they have no symptoms, requiring assistance, completely bedridden to death. You can actually put this down in a specific format. Now, when you're looking at these general indicators, the number of associated illnesses that somebody has is the biggest predictor. And then, of course, overall physical decline. Also, the features of the disease. So, look at, say, somebody who has congestive heart failure with chronic kidney disease with diabetes. You know that this is a tough one. What about somebody whose Karnofsky performance score is already down to needing somebody to be present during the bath? They've actually come down quite a bit. Somebody with COPD getting more and more breathless, or Parkinsonism getting obstipated, or uncontrolled diabetes, or COPD requiring home oxygen. So all of those tell you what is happening. There are other specific indicators that you might want to look at. Progressive weight loss greater than 10 months, which is unexplained in the past 6 months. Repeated unplanned or crisis admissions, or a sentinel event like a serious fall or the loss of a spouse, and serum albumin less than 2.5. So that is another marker. And you have, of course, disease-specific guidelines. I'm not going to go into the details except to point out salient features from each of them. For instance, in cancer, if somebody gets metastasis after initial therapy, or if their general overall functioning has declined, both of these are indicators. And here we come back to our retired businessman, and let us see how his trajectory went. So he got a left hemicolectomy, and post-operatively he was referred to an oncologist. And as so often happens, the oncologist didn't speak to him. The oncologist spoke to his daughter, who had gone along with him. And 6 months of chemotherapy, which he tolerated well. But as this chemotherapy went on, what the oncologist did not know is that his US-based grandson identified the need, the impending need for palliative care, and made sure that the old man was put in touch. So as this was going on, the palliative care guy was also on the scene. Not that the oncologist knew or it mattered, but anyway. After that, the oncologist had this 3 monthly follow-up, except when he had to go to the US. Okay, so we'll come back to the story a little later. Let's look at, say, something like COPD. Here it is at least two of these following criteria. I'm not going to read them out, except that you can actually tick these off in patients of yours. The same for heart disease and somebody who's in heart failure. Again, you can find out indicators of early death. In chronic kidney disease, especially when somebody is in stage 5 CKD and who has difficult physical symptoms or has symptomatic renal failure with nausea, vomiting, intractable fluid overload, and if they decide not to undergo dialysis. With neurologic diseases, uh, this is relatively more complex and basically, but again, the same rules apply, except that here you also have the onset of swallowing problems and speech problems. I'm not again going to go into this in detail, except to tell you that in different diseases, you have markers for deterioration. So, what happened to our gentleman with the cancer? In November 2017, a follow-up PET CT actually picked up extensive metastasis in the liver and lungs. And his expected survival then was projected to be 4 months. But the oncologist did offer him palliative chemotherapy with targeted therapy. These are specific new drugs where he said survival of 8 to 10 months was possible. So from 4 months, his survival could be extended to 8 months at the expense of whatever money and the side effects of the chemotherapy. But Mr. BY had been talking and thinking and discussing these. And he said, no, I'm going for palliative care. So a palcare team did home visit and hospice care was set up at home. And we'll come back to this story because we have to go back to our other gentleman. Now, if you remember, our other gentleman had been gradually declining. And if you remember this, the cancer gentleman has a story of 1.5 years. Here, this is 4 years. And in January, almost 4 years after the diagnosis, 2018, 4 years after the diagnosis of his dementia, he comes into hospital because of a bad urinary tract infection, which gets treated. But he ends up going out with a hole in his bladder with a catheter placed there. Now, he's still able to walk around the house. He's getting more and more worse. I mean, he's getting worse. And now the wife asks the neurologist, Ab kya hoga? Standard answer, this is expected with old age. So later, I mean, towards the end of that year, he comes in with hyponatremia, gets treated. And this time when he goes out, he is mute and he is completely bedridden. Now, if you look at it, both of these men had a terminal illness. If you don't agree, I mean, they had terminal illnesses when they were diagnosed. If you don't agree, you can answer and we'll discuss this later. So this, with the patient with dementia, you're looking at a broader problem, and that is frailty in old age. These are people who are deteriorating in function and where you don't have specific indicators. So here the indicators become more general, like slow walking speed, significant weight loss, low physical activity, any one of these and deteriorating performance score. And you need to start thinking whether the surprise question is applicable. In fact, you can actually do this, and this I use in my practice. So if families ask me, what is the chances of Mr. So-and-so surviving a certain period of time, I don't answer it in terms of yes or no. If I pick up, say, pointers that suggest that there are multiple issues and these issues. So I'm not saying cancer. Okay, you look at heart failure, needs assistance, creatinine a little high, serum albumin a little low, and you put these points together. Anybody who has, just hold on, I have to answer this call. Ruta, I'm doing a lecture. Anything urgent? 4:30. 4:30 we talk. Okay. So if you look at this, somebody who has more than 6 points has a 1-year mortality of more than 60%, 64%. So what does this mean? If you have 10 such patients, 6 to 7 of them will have passed away in that 1 year. You will have 4 left. Same ratio applies next year and the year after that. So it means that when you identify these, this is an individual who is very unlikely to survive beyond the next 3 years and is quite likely to pass away in the next 1 year. Now, do we tell our patients and their families these things? No, we don't. See, till the middle of the 20th century, the physician had 3 important jobs: diagnosis, treatment, prognosis. Now, treatment improved so much, and diagnosis also improved, that we stopped doing prognosis. And the skill of prognosis declined. In fact, it has vanished or actually become very, very small in our textbooks also. And yet, from the time of Hippocrates, remember, this has been one of our jobs. And prognostication consists both of foreseeing and foretelling. Now, foretelling, when you do this foretelling, as I said earlier, you need honesty, accuracy, and optimism. I'll just make one more point. If you do not commit to foretelling, remember that your foresight will also atrophy. These two things go together. So you have to commit to telling also. Anyway, when you start communicating towards the end of life, there are 3 specific issues that you tackle. One is goals of care. These have to be elaborated with the patient and family. Then you take these goals of care, what would they want in the future, and make a system which documents this information and makes it actionable. Advanced care planning actually means the process of forming a living will. And uh, when you are making medical decisions here, these are decisions that have to be shared. They cannot be the doctor, I am the doctor, I am telling you. No, these are combined between patient and clinician. So when you do this, you first confirm a shared understanding. What does the patient know about the illness? Do they know their prognosis? Elicit personal goals. When you look ahead, what do you hope for? What would you like to do? And if the patient lacks capacity, then you have to find out for the family uh, what the patient would have wanted. You clarify these goals. Are they curative, palliative, or both? And then you recommend treatments that are consistent. Ideally, each such encounter should end with a summary, which can be documented, and you keep revising this over time. So you will have understood that if you look at this, shared decision making, goals of care, all of these end up in advanced care planning. So it's a process where people identify their values and preferences for medical care. The most important step that they need to make is to designate a surrogate decision maker. This is important because when you are making decisions, when doctors are making decisions, they need to know who they will have to be speaking with. And this has to be done in advance of a medical crisis. And actually, you can do this at any age or stage. If you do this well, there are multiple benefits. It decreases burden on surviving family members, and it actually decreases use of unwanted hospitalizations and CPR at the end of it. The problem is clinicians don't have time, and patients, because they fear death, find it difficult to talk. But given requisite skills, it can be done. Again, do you think we can do all of this in India today? Is it possible, legal, valid? Again, I suggest you put in your comments in the chat box and I'll look at that towards the end. So now come back again. I'm leaving our gentleman with cancer, coming back to the bureaucrat. Well, this was his bad year, the year when he went down so rapidly with 2 admissions. In January, the subsequent year, he gets fits and he has recurrent fits, comes into the hospital, gets intubated, treated. Um, there's no obvious cause that can be seen. But and he comes off the ventilator, but a tracheostomy is put in because, well, if somebody is coming off the ventilator, you put them on a tracheostomy and send them home. And he also gets percutaneous endoscopic gastrostomy. But between this and this, palliative care got involved. So there was a lot of discussion on this, and finally was discharged for home care. And in fact, the American, his son who came down from the US said, "Could you not have spoken to palliative care before you did the tracheostomy?" I was involved a little later, so anyway, that is besides the point. When he was discharged this time, he was effectively in the vegetative state because of severe dementia. And he had to be taken home with his 82-year-old wife. They managed to put in caregivers, and our palliative care team managed him with phone liaison, but he continued to develop bed sores and finally passed away in 2019. Not a very good death. So when somebody is in this kind of stage, there's a lot of decision making that has to take place. One is how do you maintain fluid and food intake. The second is where do you take care of them? If it is in the hospital, then is it in the ICU or is it in a kind of a hospice setting, or do you manage at home? Do you do CPR? Do you do invasive ventilation? And so on. And all these are decisions that ideally should have been taken much earlier. In our patient with dementia, unfortunately, the patient, by the time the diagnosis was made, perhaps in the beginning could have taken these decisions, but later on he could not have. But our cancer patient could take these decisions. And because he took these decisions, and because the family was part of it, look at the way his end went. He had these prolonged discussions with the palliative care team, uh, in which his daughter and grandson participated from the US. The grandson had graduated, got a new job, but he took 2 months leave because he said, I want to be with Nana during the last months, because everybody knew that these were the last months. PC team discussed anticipatory grief, and as the old man declined, the daughter flew in just in time. And he met her, spoke to her, and as soon after the day after she came, he passed away. That was the kind of death that many of us would want. So you can answer this, but I'm sure you know what the answer is. Right. So we move on to the question of terminal illness. Now, what if you do not have such clear-cut diagnosis? One dementia, the other cancer. Remember that terminal illness is actually defined as something from which recovery cannot be expected with the available treatment, and death is considered to be unavoidable in the foreseeable future. So this does not really require a specific medical diagnosis. And again, do you remember the death of anyone close to you? Let's see if you have any things to put up in the chat box. Now, when somebody enters the process of active dying, these are the hours or days preceding death during which the patient's physiological functions wane. And as I said, the terminal phase to the period of active dying is a period of a fair amount of uncertainty. But once you reach active dying, then an experienced palliative care physician will generally be able to make out that this has begun. And it's important here to reflect back on maybe the death of someone close to you. And I would also say it's important for us as a little bit of meditation here to imagine your own death scene. So let me take you to the deathbed of our last patient. This is a lady of 79. She's not in her 80s. She's younger than the two gentlemen, but she has difficult to control diabetes. Difficult. On insulin. In 2017, she developed multiple skin abscesses. She's admitted twice, given intravenous antibiotics. Remember that indicator, multiple admissions. But finally, she's discharged for home care with daily dressings and pain control. And although the abscesses are under control, they've not gone away. In September, her activities begin to reduce. She gets into bed, needs help, except feeding, which she's able to do. but her appetite has gone down, her intake of food and water is down. And in November, this started in June, this is November. The second week of November, she becomes confused, a little restless. She's not speaking, just moaning. Hands and feet become cold. She becomes incontinent. Till now, she's always been able to tell when she needed to pass urine, and she's passing small quantities of dark urine. 3 days later, she stops speaking, and then she stops breathing. So, actually, this can be any patient. You would say incurable illness. Would you think of diabetes as an incurable illness? Yes, in this case it was. So remember that again here, if we go back to our approaching death questions, the surprise question was answerable, the general indicators were answerable, and the decision was answerable. The decision was to no longer go to hospital. Um, so this terminal illness is a variable period under 1 year. As I said, repeated admissions is one marker, needing daily care is another marker, increasing burden of symptoms another marker. And when you get to this stage, you need to actually be very clear in explaining this to the patient and to the caregivers. How much do they understand? How much do they want to know? You have to explain uncertainty. We really will not be able to give an exact time, except that we can show the trend. But you find out the patient's wishes about place of care. Like the old lady in this, at one point when this discussion was had, she said, I'm not going to hospital again. And remember that these wishes and plans may change. And then she entered the phase of, the first phase was, we call this pre-active dying, where the activities sharply declined and started needing help with all basic activities. And then came the period of active dying. Remember that when the patient transitions into this period, the reduced requirement of food and fluids is because the body is shutting down. It's not that the patient is not hungry, it's because the patient doesn't need the food. Total fluid requirement drops to about a liter per day, and you, if need be, you can give it subcutaneously. We do not recommend Ryle's tubes at this stage because they are they're very uncomfortable and they don't reduce the risk of aspiration. IV fluids also are in the same way difficult to manage. So subcute fluids are very easy. And the other thing that you do is you hand feed or with a spoon. The aspiration risk with this is manageable. It's actually the best way of managing these patients. So subcutaneous fluids if required and hand feeding. You have to make sure that they pass urine about 3 to 4 times a day. That's usually enough. Check with whether there's pain, check for breathlessness, and you don't always need medications. You can also manage with fanning the face, stroking in the back. We avoid giving oxygen at this time if we are sure that we are not going to be, that this is terminal. If there's anxiety, restlessness, and confusion, look for causes like pain, catheterize if need be, and then, if at all, you can use medications like haloperidol. Do not tie this kind of a patient down. It's not nice. It's very, very uncomfortable to the patient. You stop all medicines because families will be focused on putting in that last capsule of B vitamins and so on. Cut out all these medicines, except the important medicines that need, say, for instance, like in Parkinson's, you need to continue those medicines, or somebody with epilepsy or diabetes. And as far as possible, if they cannot be given orally, then see they can be given subcutaneously. As the patient goes down further, secretions accumulate at the back of the throat because the patient is too weak to swallow them. They do not cause discomfort to the patient, but relatives get worried, and you have to explain to the relatives that the patient is not bothered. This is called the death trajectory. Ideally, you position the patient so that the secretions can be removed. Do not do suction. Suction is again a very uncomfortable process. And if need be, you can use medications to dry it up, like glycopyrrolate or even small dose of atropine. The end is obviously when person stops breathing or the heartbeat stops. But there are two other ends which can be very dramatic and scary. One is from my own side, fits or epileptic seizures. Here, if the prognosis is understood, you will basically treat with subcutaneous drugs only, midazolam or anti-epileptic. And remember that the patient gradually becomes unconscious, quiet, and passive. The other very dramatic one is when somebody has oral malignancy, infiltration of the neck arteries will cause hemorrhage, and they can actually die because they lose rapidly 2-3 liters of blood. So when this happens, again, this is something that has to be prepared for in advance. You manage it with dark colored uh, cloths or towels and quickly sedate the patient. So as and when it starts, this is a palliative emergency where whoever is on the spot has to quickly intervene. Now remember, throughout all this, the family suffers as much or as even more than the patient. And you have to address social, spiritual, and religious needs. And obviously, as doctors, we are involved as. So when this lady entered the phase of active dying where she stopped speaking, this is a period of maximum 1 week. You see low blood pressure, reduced consciousness, perhaps increasing pain, and peripheral circulatory failure. And as I told you, she completely stopped speaking and passed away. If you're confirming death at home, remember you have to be very clear that you are calling it right. Look at the responses to voice, pupils, feel for the pulse, and then document it. Families need bereavement support. You have to explain grief to them. Grief, normal grief goes up to about 6 months. When it lasts longer than 6 months, when it really completely dominates the bereaved person's life, it's called complicated grief, and this may need medical help. They have to be explained that the grief will come and go. There are times when it is like it's something that they cannot sustain, but they have to understand that it will settle and they will go through this period, and most people will manage. Remember, key messages: terminal illness can be identified. You have to shift focus to symptom control. You have to recognize the active dying phase, and you have to manage family support. Uh, I'm going to stop at this point. I'm just a little short of. Do I have a few minutes? I can quickly just go through active dying.
Yes,
Hello.
sir.
Okay. So I'll just quickly go through active dying. So, amongst other things, is for months to weeks, they start reducing ambulation. You saw this in the last patient that I showed you. Towards the end, incontinence also appears and weight loss also happens. In the weeks to days, they start getting confused. Blood pressure starts dropping. Oral intake sharply drops, and they become completely confined to it. Again, if you remember the last patient, you remember that. And then towards the end, hemodynamic changes appears. The face becomes sallow, yellow. They start doing mouth breathing or irregular breathing, and the death rattle appears. Uh, there are various ways in which we can deliver end of life medications. We don't usually prefer intravenous. We usually prefer subcutaneous, but you can even use transdermal or the other route. So subcutaneous is probably the preferred. Nutrition, there are challenges for oral intake. And please remember, feeding tubes do not enhance quality, survival, or quality of life at the end of life. In fact, they make things worse. And when you're sure that the patient is in this position, absolutely do not push for a feeding tube. We prefer careful hand feeding. I tell families that let him or her eat whatever they want. Usually, uh, well, very often they get a kind of pica in the sense that they will ask for odd food items and they'll just take one nibble. And the family literally goes mad because they suddenly ask for something unusual and then you try and get it and they'll just have a little bit. Hydration you can manage with good mouth care and ice pieces. If at all artificial hydration, say subcutaneously or whatever, you have to make a careful decision about it. These are medications that, well, can generally be dropped. So intravenous antibiotics, aspirin, statins, vitamins, antidepressants, all of these can go. Insulin, you may if you are able to manage it. You have to ensure the patient's comfort, make the end of life peaceful and dignified, and make the memory of the dying process as positive as possible. Uh, I think I will stop at this point. Right. Thank you. Hello. Yeah. So I've stopped sharing and uh, yeah.
Dr. Sunil? Dr. Sunil, can you hear us?
Hello.
Yes, sir. I think Dr. Sunil is not available right now.
That's okay. That's okay.
Okay.
So
So I think we have another 50 minutes. We can have a
Yeah,
discussion
so
round if anybody has.
yeah, so I'm going to quickly look at the chat box and mm, okay. So yeah. Mm, Okay, so I think Mr. Chetan has asked, does willpower and positive thinking and hope play a role? Yes, it does, but you know, there's a limit to how much it can change biology. If there is a very clear cut, I mean, terminal malignancy is not going to change its hope. I mean, it's more a matter of living those days well, adding life to days than days to life. Um, Anything else? Any other questions? Anybody? The surprise question, is it for the okay? So uh, Sheila has asked, is the surprise question for the physician or for the relative? No, the surprise question is ours. Uh, we ask this internally and use this as a tool. Basically, what you're doing is bringing your intuition into play, your clinical intuition, which has, depending on your years of experience, has grown over time. And this is something that earlier people used to be a little wary of because, we thought that, I mean, what is intuition? It's too subjective. But it's been realized that with experience, actually, this is a very powerful tool. It's almost, as you get more and more experienced, its validity climbs up from 70 to it crosses 88. I'm not sure, but I've heard stories of a senior doctor walking into a room, looking at somebody from a distance and saying he's got 1 month. We've all probably heard those stories, but of course, those were in the days past when we had physicians who were totally clinicians. Right. Okay. So Angela, before that, yeah. So Meera has said, seen a case of oral malignancy, could do anything much at that time, felt very depressed. Yeah. So I understand. I mean, these are we remember that one of the things that palliative care does is empowers you to literally hold the patient and the family's hand as they transition this difficult period. Once you've learned these basic techniques, you will never again feel helpless. Uh, right. Yeah. Angela has commented, I'm sure everybody can read it. Death of my uncle about a year ago, presented seizures, multiple brain mets, passed away within 3 weeks. Within the first week, he asked whether he would live for another 3 months. And this was a surprise question. So the surprise question can come from the other side also. Uh, yes, does documentation help a patient in any way? It absolutely does. Because for one thing, it sorts out the family. the family then doesn't, get desperate towards the end, because if they know what the patient wanted, that becomes their guidance. And for the patient also, knowing that they have control, they have charge towards the end, it's very powerful. One of the things that hurts everybody is the fact that you're going to be helpless, that you are not going to be able to control anything. But yes, but if you put down your wishes and you're assured that your wishes will be carried out, it's actually very powerful. Yeah. So he was very insistent that he didn't want to investigate or under him. Yeah. Okay. So again, uh, Sheila Rathod, yes. So I understand. I mean, you will see that more and more often doctors who are aware of palliative care manage to make sure that this is available to their own family members. Mm, right. Does anybody?
So I'm Dr. Sashikla. I think this
What?
class brought me back a memory of so many years ago. I just got married and came to my locality. I was a young doctor, and our neighbor, she was about 90 years old. She was demented, and she had a son who took very good care of her. And he called me at 7:30 in the morning. He's a very thorough person. He wanted to do everything possible for his mother. So he told me, I want to take her to the hospital. And something told me, like when you told about intuition, I think it just struck me. Something told me, I said, no, I don't think she wants to leave this place. I think you should just give me half an hour's time, because she was having something like a jaw breathing, and I thought, she's not going to survive, another trip down to the hospital. And I still remember her face. She caught hold of my hand and gave me a smile that it still makes me emotional. Like something like it's like a blessing. And just as I thought, by 8 o'clock she died, and she was very happy. And that scene always that was what taught me there's a dignity in death. And I mean, when we spoke about this today, I just got reminded of that. Thought I shared.
Yeah, absolutely. Thanks for sharing that. And absolutely, I mean, that's what patient choice and autonomy is all about. So, Angela, again, about a father who suffers from COPD and who's already planned for what he wants. Yes, so he is in charge. And that is going to be a very powerful thing for him. The fact that he is in charge, that he's making these decisions.
Can I speak?
Yeah, please go ahead.
Yeah, my father's story was like, he had a MI, and he had standing 2 times, and he was in and out of ICU, very critical, but many times he survived the admission, and he came back home and lived for another 3-4 years, then had another problem, and again went into the hospital and survived that and came back. So actually, when the next time he became breathless, he was taken rushed to the ICU. He didn't want to be there, but then we didn't know whether this was going to be the last time, because he's already survived multiple times, very precarious situations, but he survived and come back. But then he always used to say that he never wanted to die in the ICU, but then that particular time he didn't make it. So how do we know then? I know, I still feel bad that he had to die there in the ICU with all the tubes in his, uh, you know, nose and mouth and everywhere. But many times he did make it because of some I don't know whether it was the ICU treatment or what it was, but he did make it. But we couldn't make the right decision at that time, so we can never say, I guess.
Yeah. So there are two things that we look at in this kind of situation. One is these are decisions that have to be talked with a doctor. What if this happens? What if that happens? And if the patient is able to talk, then we try and put these down, these decisions sort them out as much as possible, because as somebody undergoes medical conditions, the medical problems that they are likely to face going forward become clearer and clearer. You will know that these are the 2 or 3 different things that are going to happen to this individual. And you will be able to ask him or her what he would have wanted. So, for instance, whether that person would want to be intubated or not. That's a very clear-cut question that patients almost always answer. And having done that, you have another option, a powerful option, which we don't often use. That's called a timed trial of ICU therapy. So when somebody is in this kind of a uncertain trajectory, they go into the ICU only for a very defined period of time. So it could be, typically it is anywhere between 2 to 5 days. Ideally, about 3 days is the time that you know whether somebody is going to turn around or not. And if the situation is not turned around in 3 days, then you try and move over to making them comfortable. Now, of course, in somebody who is in an ICU, you may not be able to get them home, but at least you can see that the tubes are out, that the family is around, that comfort care measures are instituted, and whatever has to happen happens in a room, not in the ICU. Okay.
So can I ask a question, sir?
Sure, go ahead.
So like we have a 87-year-old man, and like he had made a clear-cut idea that he didn't want to be ventilated. But recently, just 3 days back, he had one episode of convulsion after fall from bed, and then we had rushed him to the hospital. And after they had to intubate him because he had aspirated and all. Against his, he told that he didn't want to intubate, but at that time we had no option. We had to intubate him.
Fair enough.
Because of aspiration. So is that a contradictory? Because he told he didn't want to, but this was an acute episode and there was no option. And he survived, sir. Now he's extubated and he's doing well also, sir.
Okay, so this is a little tricky. Now, in the advanced care plans, in the living wills, the individual concerned has a choice of allowing discretion to the surrogate decision maker or not permitting any decision. So you have instances of people who were in this kind of stage and who were brought back. Well, it has not happened in India, but in the US people have actually been sued, and it's called wrongful life. Really, wrongful life. This is a major category of litigation there. So typically, the way it is handled is that in the living will or in the advanced care plans, you ask that individual, are you willing to leave this decision to somebody else? Or are your wishes, the way you have said, they have to be carried out, even if you die? And if the individual says, I want these wishes carried out, then so be it. But that discussion and that documentation then is important. So does the surrogate have the discretion or not? If you look at there's a document, the living will document. The format is there on the PALIUM website. You can download it. It's the one that we worked on. And in fact, where we identify surrogates, we have this option. Are you giving discretion or are you not? So I'm sure in this case, because we have not thought this through, whatever, it turned out well, as long as the old gentleman was not complaining at the end of it. So I'll tell you a short story. And this is a real story. This is from a friend of mine who was working as a registrar in a UK ICU. And an old gentleman was admitted. And during my friend's shift, the old man arrested. He was admitted with cardiology. So as always, everybody jumped in. The old man was shocked and the heart restarted. And then they settled down, and an hour later it happened again. And then it happened again. So thrice he was shocked, thrice he was awake. And as my friend was finishing his shift, the old man was fully awake. And he told the nurse to call my friend, to call the duty doctor. And as my friend came there, he expected to be thanked. The old man took his hand, held my friend's hand and said, young man, you will not do that again to me. So this was the UK. So obviously the cardiologist came in, the palliative care team came in, the gentleman was shifted out of the ICU, and he passed away 3 days later. So
Yeah.
the point is this choice. We don't discuss this. These choices are not given. Right.
So about the living will,
Yeah.
like I mean, what is the legal status? I mean, I'm really not sure how legal it is in India.
So if you make it, Narendra Modi will come running after you to put you up, and he will bury you in that Central Vista.
No,
So I mean, hang on, I'm just joking.
I'm
I mean, if any of you
for
is
a
on
recent,
that side, it's a different thing. So the thing is that the living will has been validated by the Supreme Court. What the Supreme Court has not done is make it enforceable. The Supreme Court could only say it is valid. To make a law that says if you see a living will, this is what you can do, this is what you cannot do, for us, for doctors, and tell us that this is the way it will be enforced. If you do not follow these instructions, this is what will happen to you. That has not been done. So it is valid, but not enforceable.
no,
So what is the use? So what is the use of it? What is the use of it?
I know.
The use is that if the family, if it is done in consultation with the family, and if the doctors understand this, then it makes for a great deal of clear decision making towards the end of life. Things get sorted out, and nobody and I can assure you that it is more than adequate protection for the doctor who follows it.
No, I'm asking this for a specific reason because my father-in-law passed away after a long, 1 week long ICU, agonizing ICU, stay, because my husband, being a doctor too, like, he didn't want to give up on his father. But after seeing that, my mother-in-law, she says, I don't want any such thing to happen to me. So she has written in a small piece of paper and kept it in one of the books, and she's told me that I'm putting you custodian. You are not supposed to do things like that to me. You are supposed to let me go. But I mean, so I'm just finding out what is the legal status. She says if there is, because when I told her I'm having a class on end of life today, she asked me to find out how she
So
can.
I'm answering that.
Legal, yes.
So I'm answering that.
Thank
So
you.
download the form, fill it up. Now you will see in the form that to make it enforceable, it requires a judicial magistrate first classes counter signature. Unfortunately, those orders have not been passed, so the lower judiciary doesn't know about it. What you can do is see that it is signed off by 2 witnesses who are preferably not relatives.
Okay.
So you'll see that the instructions are there. It's as clear as can be.
Thank
you have it filled up by her,
Yes.
and she has the right to. I mean, she has the right to give you the discretion, make you the surrogate. Because when we appoint surrogates, like, I'm sorry to put it this way, but she may say she may not want her son to be the surrogate because he's too attached,
Exactly.
or whatever.
Exactly.
She may say, I want so and so. I want somebody who understands what I want. So, but that is her choice.
Yes. That's precisely what she told me, that you have to decide at that point of time. That is why I'm giving you this piece of paper. So now I'll take that and get it signed from her, because
Make
she
it.
values that a lot. It means a lot to her.
And tell her that whenever you go next to your doctor, whoever it is, let her only show that form to the doctor and make sure that the doctor accepts it, because then you are there, the doctor is there, and she has put down her will. That's it.
Thank you so much, sir. Thank you.
Yeah, I think your husband also need to know this, because otherwise there will be problems. And I don't know if you say don't put him on ventilator, he will comment, no, I want him on ventilator. So tell your mother-in-law that it should be discussed with your husband also.
I'll do that.
Yeah.
So I think that was very informative, because everything was practical. So let's move on to the patient story now. Today's patient story will be presented by Dr. Annie Mary.
Am I audible, sir?
Yes, doctor, you are.
Yes, yes, very clear.
Yes, yes. Yeah. Good afternoon, everyone. This is Dr. Annie. I'm a consultant pathologist in Herbertpur Christian Hospital, Uttarakhand.
Where in
Can
Uttarakhand
I
are you?
go to the next
Sorry?
slide, please?
Sorry, where in Uttarakhand?
Sir, Uttarakhand, Dehradun, sir, Herbertpur, Dehradun.
Dehradun.
Dehradun district.
Okay, okay. I didn't. Thanks.
Yes, sir. Yeah. This story is about a small child. Actually, I'm a consultant pathologist, so this child is being taken care of by my husband, who is a pediatrician. So I have taken this case from him, and the patient is 9 months, 12 days old, and he's a male, and his diagnosis is severe bronchopneumonia with wheeze, tracheostomy tube obstruction, protein energy malnutrition, and GERD. Next slide, please. The presenting complaints is the little one was brought with the complaints of cough for 2 days and breathing difficulty since 1 day prior to the presentation. And also the little one had a difficulty to feed the baby. Next slide, please. The history of presenting illness is like this. The baby was depressed at birth and he's meconium aspirated, meconium stained aspirated amniotic fluid, and he was requiring at birth itself IPPV for 7 days. And he also had a history of pneumonia at 3 months of age. He was then intubated, and however, he had multiple extubation failures. He was ventilated for 1 month at Dehradun, referred to PGI, and was admitted there from June to August 2020. He was ventilated all through with
Hello.
I think we lost her.
Okay. Yeah, we can read through it fairly detailed.
Dayalakshmi?
Yes, sir. He was ventilated all through with multiple extubation failures, causing of prolonged ventilation was not clearly though. He underwent thoracoscopic diaphragmatic plications of lateral dome of diaphragm on 17 July 2020. However, this was not helping child better, so underwent tracheostomy at 4th August 20. After multiple failed TPs trials was started on BiPAP and discharged at home on 12th June settings with 5 liter oxygen from oxygen concentrator. Baby was doing well on these settings. Baby was admitted and treated in HCS, that is their hospital, from 27th to 7th 12 with diagnosis of bronchopneumonia with wheezing and tracheostomy tube obstructions. During the stay in our hospital, baby steadily improved, started on oral feeds and was discharged with BiPAP. Stomach closure was not done. Home visits and consultation over phone was being done. Vaccinated till date. So on examination, rate of a child, Dr. Annie, can you unmute from your end, Dr. Annie?
I'm not sure if she's there. I think go on.
Yes, Dr.
Yeah,
Annie.
she's here.
Am I
she's here.
audible?
Yes,
Yeah.
Yeah.
Yes, yes.
Can I say the previous slide? I missed the last line. Was it told already?
That was,
Yeah, it's already
it
done.
was-
Okay. Please go to the next slide. Baby's weight was 4 kgs and he was gasping on general examination. Pallor was present, but there was no icterus, clubbing or edema. On respiratory system examination, there was absent air entry and no chest raise. And CVS wise, he is fine and no murmurs. And milestones, gross motor, he has a poor head control, and fine motor, there is a bidextrous grasp. He's recognizing strangers. Vision and hearing seems normal. Next slide, please. treatment and significant investigations. Initially, baby was gasping, hence immediately suction was done and started on AMBU, followed which air entry with wheeze could be heard bilaterally. Baby is then shifted to ICU and kept on BiPAP with nebulization. Baby was started on empiric antibiotics. Chest X-ray showed right-sided patchy infiltrates. Baby had several episodes of desaturation for which suction, bag, and mask ventilation was given. During such episodes, one's child suddenly had bradycardia followed by cardiac arrest within the next 2 minutes. CPR was initiated and 3 doses of IV adrenaline was given with no response, but baby had gasping breaths. Calcium gluconate was also administered. CPR was done for 20 minutes, after which death was declared at 12:15 a.m. on 17/12 December 2020. The significant investigations are CRP is 106 and total count is 17,700, and culture on ET tube. There was a moderate growth of Klebsiella and heavy Staphylococcus. Next slide, please. Coming to the psychosocial aspects, definitely parents, both the parents are anxious and depressed about their child's status. They were unable to take child to the primary treatment center in view of travel restrictions, as that was also a lockdown time. Finances and distance being 4 hours, and shifting the child was also very risky for them. And local practitioners who are available in and around, they refused to take care as child is 9 months old and managing tracheostomy was alien to them. The father, who is the sole earner for the family, had left his job to take care for the baby. And before they were in Dehradun, and they came back to their parents' place in Herbertpur to take care of the baby. Per month, expenses for oxygen and rent for BiPAP machine is 15,000, and also medicines were coming up to 3,000, and it has to be borne by the pension of the retired father, which is not coming up to the same amount which they are expending. Baby's parents have much anger towards God for baby's survival and death. Next slide, please. Medications majorly given were antibiotics, nebulization, Pantop, and the pediatrician has stressed on high calorie and high protein diet. Next slide, please. The main concern was to our hospital and our pediatrician and the team, the parents. Main concern was about availing fees, about adjusting the finances. Next slide. Next slide, please. Yeah, to summarize, it's a 9-month-old baby boy who was depressed at birth, meconium-stained amniotic fluid, requiring ventilation support for many times, underwent tracheostomy, put on BiPAP, oxygen support, and was diagnosed with severe bronchopneumonia with tracheostomy tube obstruction, died during the course of admission despite of all the medical interventions. The point to be discussed for this story, for this little one, is how can we manage this patient in a feasible and effective way for all the treatment? And also the second question is like, how can we help the parents in their grief? Thank you.
Thank you, Dr. Annie.
Thank you, sir.
So I welcome opinion from any of the participants.
Right. So one question that I would have for, let's start with Annie, Dr.
Yes,
Annie.
sir. Yes, sir.
At what point in this trajectory were the parents told about the prognosis? Was it ever discussed with them?
Yes, sir. Yes, sir. The patient the little one was brought to us for the twice, sir, to our hospital. And when the little one has come for the first time itself, our pediatrician has actually spoke with them, because they are being undergoing this from the baby's birth, sir, since birth. So we have actually, he has actually spent time and speaking with the parent, because when the parent has got him, especially the father, who looks a little educated and who has come along with the baby for the first time, he looks very depressed at the time itself, and he was found very lost out. So so our pediatrician has spent some time with him, and actually we have gone, like our little team has gone to their house visits also, to explain them the prognosis and to be with them in all these days. In the second visit only the baby got expired, sir.
Yeah. Dr. Sunil Kumar?
I was asking opinion from the participants.
So the multiple ventilatory support can could have been avoided, sir. Like when we knew the prognosis was not good, like bunch and with tracheostomy, we could have just given the palliative care to the baby and avoided the intubation. Was that possible? I mean,
Actually, the
what
father
was
was
the Apgar score? I mean, initial on birth. I mean, generally,
the Abgar score was like some 4 or 5. Because baby was born here, but it was like 9 months before we weren't there here. So a baby was immediately referred because of the very poor prognosis. As at that time, few things were not available in our hospital, so baby was taken to PGI immediately.
Mm.
After that, only after 9 months, baby has come to our hospital.
Mm.
Okay.
Right. Anybody else? Right. So, in these situations, what do you think was the primary factor that drove this whole trajectory?
Hello, sir.
Yeah.
Initial resuscitation in the immediate period, postnatal period, that itself, that baby was having a very poor Apgar score at that time, means prognosis should be bad to be anticipated, no? Then the further management, everything's too much of ethical problems, or that that everything followed us. Whether to say which is correct, which is wrong, very difficult to.
Yeah. So, yeah. Somebody is saying something.
So can I add on? Yeah, can I
Yeah. Go
add
ahead.
on here, sir? So actually, what I understood from the father is because from the second visit when my husband is talking to him, I too was there. So the father was insisting the treatment from the beginning, sir. He was told, he agreed that he was told that the poor prognosis in the beginning itself, the financial, everything, the crisis that would come on the way. But the father went to an extent that he wanted to give his child whatever they can at that time. And he even left his job to take care of the child. And they didn't even plan for the second baby because they wanted to concentrate completely on this baby. The father was like actually fighting for this child until the last. So that is what we understood when the father has come to our hospital.
Mm.
Actually, more of counseling for the parents needed. Maybe they were too much emotionally attached, and so it is a painful experience for them. So more and more attempts to make them convince, or that is anyway, there is a very poor or meager chance to have a good prognosis for this baby, no?
Yeah.
and the baby also would have gone through so much pain. So such a
More
small
than
baby
that,
on
the
BiPAP
number of
and
intubations, the baby would have actually, because it is, can't even advocate for its own self. So the baby would have
Yes,
undergone
yes.
so much of trauma. And I don't know, somewhere somebody should have been able to, understand, tell them that it is understandable that you have so much of love for your child, but that itself should not be the cause, no, that is our Atma, no, that should not be put to so much of trauma. So I don't know, if it was my child, I would have said, no, I don't want to torture that child
So,
anymore.
so I'll just come in at this point. See, one of the things that happens when we are counseling families, and even as doctors, we when we deal with adults, you're speaking to an adult who's making decisions. You are valid in offering a menu of choices, but here you're dealing with a vulnerable individual, where the families also, the parents also find it very difficult. So you have to offer what you think is the best option. So that menu that we normally do is not good. So I suppose at some stage, when you give that menu, we can do this, we can do this, we can do this, we can do this. Uh, yeah, then these things can go on like this. Whereas maybe it was possible earlier if somebody had uh, spelled it out to them that this was the best possible choice. It might have
Sir.
worked. But then over a period of time, then everybody gets locked into a certain course of action. Then it becomes difficult to change.
Mm.
Actually, people are hesitant to say the truth, and that is
Absolutely.
very.
Remember what Dr. Rajagopal told, it is that when you say that you cannot offer anything more in the form of treatment, every doctor feels it's somewhere they're accepting failure. I think that is where your menu keeps, going on to things that you can actually do theoretically. So I think basically that has to change. I would have been like this before if I had not attended this. So I think that's where the change has to take place.
Yeah. So you have to
More-
make. Sorry, go on. Somebody is saying something.
Sir, more of a supportive treatment rather than this much of intensive treatment would have been better. Then
So
baby would not have suffered so much with the
So at some
tracheostomy.
stage,
That sort of
So at some stage,
treatment
as
could have been-
medical practitioners, we have to make this commitment. You actually, you don't say, I can do nothing more. You never say that. You actually have to say that, but I will be there. This cannot be cured because at some stage, the family will ask you, the parents will ask you, the patients will ask you, can this be cured? And the answer is no, this cannot be cured. But I will take care of it. Or I will take care of the baby. We will be with you. And making that kind of an explicit statement of support, it's important. You have to. For me, the turning point came when I realized this was almost about a year ago that I had stopped saying "Ab main kuch nahi kar sakta," that I can do nothing more. I don't need to say it because care is always possible, and giving that assurance is something that makes all the difference.
Okay, so if this patient has not gone for ventilation, then how would we manage this baby? What can be done? Anybody? We know supportive care can be given, but what are you going to do actually?
baby had severe meconium aspiration, that problem, no? So maybe he was in real respiratory distress or something like that. So we could have managed with some oxygen hood or that kind of oxygen therapy, plus then nutritional attention, then treatment of infections also, because they can go for pneumonia at that time also. So anything more? I don't know.
Anybody
Because
else? Oh, yeah.
too much the resuscitation in that age, no, that because brain would have already suffered hypoxia, like so that anyway that outcome will be bad, no. Brain development most probably will be poor. So
okay.
Sepsis is always the tipping point for patients like this. So actually, we never know. We have the parents definitely will not know. Will bring the patient to the hospital, and if it's a normal case, sepsis can be treated and patient recovers and goes back. So it's actually a very dicey situation. We can never say how long, and sometimes with that sepsis can take the child's life as well. So I really don't know where we can draw the line.
Excuse me,
Okay.
sir.
Yeah.
Excuse me, sir.
Yeah.
Actually, I have one doubt. Actually, whether the same protocol of care of the there's end of life care we can follow for both this in pediatrics and in patients with other terminal illness. Actually, in pediatrics and small babies, in many cases they are having some, they are improving much without much, in spite of our impression that they won't survive and all. It can happen also sometimes, no? So can we follow the same protocol in the adult and the pediatrics, or can we follow a little bit more of a what we can wait, or we can try, or we can still give treatment to improve the condition like that? Can we, what's the opinion, sir?
Actually, we can watch the prognosis and decide. No, actually, the child was going bad. The child was not at all improving. Like, if the child was showing signs of improvement, we could have gone for further uh, escalating the treatment. But here, the child was going bad only. No.
Okay.
So,
So,
sir, what will be your answer for the question that you asked, sir? Because you asked us the question. So, what will be your, I mean, what will be your answer, Sunil sir or Roop sir?
okay. First, Sunil, then.
Okay, no, I was thinking that if this patient was not put on ventilator, the baby might have respiratory distress, which I don't know whether we will be able to manage with oxygen nebulization and things like that. So the baby might also need some morphine, I think. So maybe a very small dose, which could take away the respiratory distress. So I think if I were the person, I give will give you some morphine and will try to reduce the respiratory distress.
Okay. So I'm actually taking this back right to the beginning. And if you are making these decisions right from the beginning, the questions that needed to be asked is the child going to be cured? Or at least, are you going to be able to prevent progression? What will be the child's quality of life as this goes on? Will the child's symptoms, I mean, at least at the time of the tracheostomy, will it improve the child's symptoms, or will it make the child feel worse? If there is a chance of getting better, how long will the child feel worse for? And if you don't have the intervention, what will happen? So these are questions that at some stage through this long illness should have been discussed back and forth till the parents were satisfied with the answers. I mean, at the end of it, it's quite possible that parents may still take decisions differently, but that's a different thing. Am I audible? Sorry.
Yes, yes.
Yeah.
Yes, sir.
So I think.
Yeah. So if the prognosis of this patient is very poor, and we know that further ventilation and things like that is not going to give a good quality of life for the baby, then I think we would discuss with the parents regarding the same. So and take their consensus and go forward. Sometimes the parents may not agree with you, and they may want to do all the possible things. So maybe we have to again talk to them that we can do a trial on that trial basis, and we will see this much days. If there is any improvement, we will continue. Otherwise, we would not escalate the treatment, and we will withdraw the ventilation. So that's how I think we can move forward in this patient. So even if this patient, so this is from the first at birth, and if the patient has ventilated and one or two times, and then also we then know that this baby has a chance again to go for infection and ventilation like that. So those are the times during which we have to talk to the parents and come to a consensus, because there will be some time during which we have to actually make them understand this is not going to be beneficial, and you are actually making the baby suffering more. So I think it is our the team should be in conversation with the parents, and then only we can do this.
I agree.
And what was the second question, Rajeshri?
Bereavement. They wanted to.
Yeah.
Bereavement
How
support.
can we help? Yeah. So, anybody want to talk about bereavement support?
So can I say at this point?
Yes.
Yeah, our team was there until the death, and even after that, the father comes to our OPD, and he just wanted to sit and speak to us because he says that he has a feelings of going back and digging the grave back and taking the child home. So it was very terrible for the father. So he told that in the middle of the night when his wife sleeps, he just wanted to get out of the house and get the body back, because he got used to take care of the child all these 9 months, and he's not able to accept. So we could offer like sitting with him and talking our counseling team. So doing the home visits and all, he often comes back to us. We are encouraging him to get back, because he's a very good educated person, where he was doing his previous job in Dehradun. So getting back to his normal life, but he's not as much as ready as how we are asking him to be.
Yeah.
So this is how this is one thing which we are facing with the father, especially. So the father is very much attached to the child. Yeah.
Complicated grief.
Sir, do you want to?
Right. I think we are done. This is a risk in a situation like this, that the surviving person will be uh, locked into this cycle of complicated grief. And if it doesn't settle down with counseling, I would even think of asking the psychiatrist to work
Yeah.
with it.
Yeah. And
Yeah.
he just expressed that he was happy the way the baby was taken care in the end in the hospital, which the baby was not taken care before, because none of them had explained him, especially about the prognosis or the way the things are going to happen in the life. So he was that was not expected from a father who has lost the child, but he was very polite. He came back, and he told that he liked to visit the hospital and just speak to us. So that is really a good of him, and the way he spoke to us, sir. That's so nice of him.
Okay. So there are many factors which can lead to complicated grief, and the death of baby is one of it. Uh, so it is sure that both mother and father might go through severe grief reaction, and I think this father needs some medications to help him with for sleep and things like that. So definitely, along with the non-pharmacological management, I think he needs help from a psychiatrist.
Right.
Yes.
Okay.
Sir.
So I think we can wind up the session for today. So thank you, Dr. Roop, for a